So very good afternoon. Now we are coming to our instruction course, the terrific longest day in my retina practice. I'll invite all the speakers to come into the dais. Uh, Dr. Aditya Kelkar, Dr. Aniruddha Maiti, Dr. Reddy, Dr. Shobhik Da, myself and Dr. Debdulal Chakraborty, please. So we will start with the talk of Dr. Aniruddha Maiti.
Yeah, thank you, Dr. Borel. Well, I will be showing few cases other than diabetic cases where the intraoperative bleeding has caused or rather increased the duration of the surgery. This was a very simple case of drop towel. As you can see, we have lifted up the towel. Everything was smooth. Now the last step of taking the owl out. Now something went wrong. The haptic got badly stuck with the iris.
लोड किया हुआ
Generally, it's just there's a little bit of hindrance which come out very easily, but that was not the case over here. It started bleeding profusely, both in the anterior segment as well in the posterior segment, and with a lot of maneuvers, actually, the IOL was so badly stuck we could not free it. So we put some visco, tried to flip the lens, but things worsened. It was more bleeding, both in the anterior segment as well as in the posterior segment. Now we took the lens, flipped it entirely, which ultimately helped, and we could take it out. In fact, in the process, the haptic was also broken. So this is a rarest of event, but this can happen. We need to be very careful. And then the rest of the procedures, we took out the blood. In fact, taking out the very fresh blood sometimes is difficult and it's time consuming. So we took out the blood, and once it was clear, then we had put, and already this was we have spent a lot of time controlling the bleeding, so we had put this iris claw lens, and this patient did pretty well with the 6/9 vision. Now these are all simple cases, actually turned out to be complicated ones. Now macular hole, sometimes there is bad oozing, and in fact, in few rare cases, you might touch the retina and cause bleeding. So one of these cases I've just show. I will not say this is the longest of the cases, but yes, this can happen, and for the beginners, it's an lesson that if it happens, it's better to be patient, and eventually all bleeding stops. Nothing needs to be done. You just increase the pressure for some time, trim the blood and come out, and nothing, no laser is needed. Now this is a very rare complication where the new assistant pushed it so hard in order to push the BVG, it actually soft tip touched the retina, and this caused injury, and there was a oozing of blood. One tip or the lesson learned from this case: you should not point when you are injecting the BVG, it should not point on the posterior pole. Luckily for this patient, it was nasally, and whatever the injury happened, it was in a nasal to the disc, where we could easily manage, and this patient had a good vision with a closed macular hole. Coming to the last case, this was there was a lot of hemorrhage, non-resolving vitreous hemorrhage. This patient came a little bit late, and when we operated, after removing the vitreous hemorrhage, thick vitreous hemorrhage, we saw there's a sub-ILM bleeding. So as we know that the sub-ILM bleeding is very easy to treat, just remove the ILM, and you can just release the entrapped blood. So that's what we did, and it was going on very smoothly. So just the plan was to remove the ILM, release the blood, do some base shaving, and come out. So we have released the blood, and we were doing some base shaving. Now the problem started. This patient started coughing very badly. Bouts of coughing started, and some point of time, we actually this patient had sat on the OT table with all the instruments in, and you can see spots of bleeding coming out. And the next time when we went inside, the things were worsened. There was a choroidal detachment, choroidal hemorrhage, and in order to push the instrument inside and induced and retinal detachment as well. Now it was more difficult than the primary case, and as you can see, a very thick hemorrhage has already formed in the posterior pole. So gradually cleared the hemorrhage. The first thing was to clear the hemorrhage and then deal with the choroidal hemorrhage, choroidal detachment, and the RD which has induced superotemporally. So we did an FGE. Did some cryo as well because it was not accessible. Then after putting the oil, we did a good laser, and the choroidal detachment actually subsided spontaneously. Later on, it gave a good result. It gave 612 vision. So sometimes it is not planned. In a simple case, we can turn it can turn to your longest day in retina practice. But you need to be prepared, and you need to be patient, because eventually all bleeding stops. Thank you.
Thank you, Dr. Maiti. A nice presentation, nice occasions of like a kind of vitreous hemorrhage, sudden vitreous hemorrhage. But in your third case, what happened during the just after the cough? Like, was there any instrument touch in the retina, or the your
In the third
infusion port has been slipped away? Why there is choroidal detachment, and from
No,
where the bleeding was happening?
this patient already had a vitreous hemorrhage, but with the instrument inside, this patient was coughing very badly, and she was sitting on the table. So maybe
Some
this.
kind of instrumental
Yeah.
touch that happened. Nice presentation.
Thank you.
So I will invite Dr. Devdula Chakraborty for his talk, The Longest Day in a Year.
So I'd like to thank Dr. Shubhendu Boral and also the AIOC for this opportunity. So these are slightly, fluke kind of situations that happened. This one specially. So improvised endo illumination using mobile phone light during vitrectomy. So how actually this happened? So it was a case that was co-managed by me and Dr. Samar Basak. So 44-year-old gentleman presented with pseudophakic bullous keratopathy and with ACIOL. So vision was finger counting, fundus was not visible, and we did an ultrasound. The plan of management was corneal debridement, epithelial debridement, removal of anterior chamber IOL, pars plana vitrectomy, and a scleral fixated IOL, and subsequently DMAC was to be done. So first part very simple, remove the epithelium, and the IOL I removed it, the ACIOL I removed it, and then started the story. So went inside and this popped up. So this thing popped up, and what actually it said is that there was a system fault. So system fault, okay, chalo dekhte hain. Pulled out the light. The assistant pulled out the light and put it in the constellation sort of light cassette or whatever you call it, but nothing happened. And ultimately, the problem was that these Alcon people said that we will not be able to rectify it. And coincidentally, that particular day, the other machine that was there, that was also not working. So I was in a double dilemma. So what to do? Either abandon the case and tell the patient that this will not be possible. Patient had come from a far off place. Suddenly this idea cropped up that why not try something? So we didn't have an endo illuminator, we didn't have another illumination source, and so suddenly this idea cropped that whether the mobile phone light could be used. So what we did was something pretty simple. So got one of the assistants to hold the switch on the mobile light and just hold this endo illumination end of the endo illuminator that goes into the vitrectomy machine. That part we just held it like this. So and I tried to see whether we could see anything inside the vitreous cavity. So Surprisingly, this was visible. I hope you can see it there. And luckily, it was not a long surgery, and there was some amount of lens matter that was there in the vitreous cavity, so that we could sort of, eat up with the cutter itself. And we could just about manage. Just to give you some context, a vitrectomy machine has usually around 50 lumens of light, the endo illuminator, and this actually is there, with mobile lights also. It is between 20-30 lumens to 50 lumens in some mobiles. So subsequent to this, because the main part of the problem was solved, we could put in the SFIOL. This was the easier part of the story, and that's the SFIOL going in, and I'm taking out the haptices and trying to tug in the haptics one by one. So there goes one, and this is the other, making a scleral pocket and just tugging it in. So basically, what is important is not to lose the cool during such situations. It's not possible in every center to have a backup machine or a backup situation ready. So when something like this happens, it is the coolness of the mind which can go a long way in sort of saving the situation. So finally, closing the peritomies with glue, and that was the end of the surgery. So next up, this was a longer surgery, actually, a very long surgery. So this was a patient who had undergone a lensectomy with some vitrectomy elsewhere, and this was also a patient with NIDDIA lensectomy, because the patient, it seemed, had cataract in childhood, and the lensectomy was done elsewhere. And so see, all this is corneal opacity. It is not the iris. So what's the plan? So we did peritomy superiorly initially, and then similarly inferiorly also, and did the cauterization of the bleeders, and then at 1 millimeter from the limbus, we took 10-proline sutures, and using a railroad technique, we actually got these sutures out, and in repeatedly, and we created a mesh. So when you don't have iris, and it's a retinal detachment which needs to be tamponaded. So in this kind of a situation, you can take this help of this proline sutures and create a mesh which can work like a iris to some extent. So that's where you have these sutures, proline sutures, and once this is done, the rest of the surgery is actually very simple. This was the main worry, whether we'll be able to manage to keep the oil tamponade in the posterior part, confined to the posterior part. So this was, in fact, this was a pre-vitrectomized eye, like I mentioned, and as you can see here in the inferior part, a lot of laser marks. Actually, probably there was some, I couldn't get detailed history, so probably there was something inferiorly which made the previous surgeon actually do nice laser here. And we couldn't really find the break. Probably one of those small micro breaks that we cannot find, and once in a while. And so we did a fluid air exchange, and then put in silicone oil. So now this part one should keep in mind has a little bit of some nitty-gritties that has to be followed. So once you have injected the oil, it's important to fill the anterior chamber with BSS. So this is, I'm like closing the sclerotomy ports. Even with 25 gauge, I close sclerotomy ports. Don't like silicone oil bubbling up everywhere. So this is important. Take out the air from the AC, and this is where I take off the other cannula also, and I take BSS and form the AC with BSS, and you can see it is nicely forming up. And that is basically the end of the surgery. You have to keep the AC formed with BSS, and this is some little bit of glue that I used to close up the peritomies. You can close it up with sutures also. And the patient actually did well. Subsequent to the surgery, patient had 6/18 vision, and the patient was happy. So thank you for the opportunity. These are my two cases that I wanted to show.
Thank you, Debdural. I was really surprised that with the only, basically the fiber optic of the endo illuminator needs the high intensity light source to transmit the light. Just a mobile light, light from a mobile, like it is just it's kind of a rescue in your case. So, what is the opinion of my co-instructor? I think the panelist.
You need to have a very good mobile.
Actually, this was, to be very honest, this was just a, like I mentioned, more of a fluke sort of a situation. I didn't know that this was the lumens. I looked it up later that, how many lumens does a constellation vitrectomy machine provide? So it says it's 50 lumens.
Excellent innovation.
And this is 30 lumens in most mobiles, can be 50 lumens. So I didn't know how much that mobile had, but then actually we could do the job. So that was something interesting.
Dr. Reddy, your comment?
The mic is off.
Mic.
Actually, with the 3D visualization system, you require less endo illumination. So, with the same mobile phone light, if you're working in a heads-up kind of system, you can more comfortably do the entire surgery. I believe we can do it.
Well, we will have to try to get 3 heads up.
To decrease the cost of the illuminator. Thank you. So I'm inviting Dr. Rajirama Reddy to deliver his longest day scenarios.
Thank you, Subhendu, for the making me part of this course. I'll be presenting 3 cases. Each of them is a challenging one that we encountered, and time is basically it's relative. When you don't expect something, you tend to feel it is pretty long. First case is of a recurrent retinal detachment following post silicone oil removal. It's a 1 month old. He already has new vessels in the iris. So it was taken up for surgery after giving IVT anti-VEGF, and this is how the surgery goes. We find there is a large macular hole and there is a retinal detachment. So in this we realize that the macular hole requires already multiple surgeries have been done. So to close the macular hole, decided to have a autologous retinal transplant done from the peripheral area, the area where we plan to do a retinectomy. So chandelier light was used, and the autologous retinal tissue that is fashioned is kept under the PFCL bubble. And next the procedure as planned, we needed a relaxing retinectomy with the periphery there was a contracture in the retina, and from now on the entire surgery is under air. You can see the air fluid exchange is being done. Once the air fluid exchange is done, we see that the further retina is contracted and requires extension of the retinectomy. So further diathermy, incremental retinectomies were done under air in this particular case. So, and the peripheral retina is after diathermy is written up with a retrectomy cutter. This performing incremental retinectomy under air is something that I routinely do. It gives more control over the extent of retinectomy that is required, but visualization needs to be good. And almost like a 270-degree retinectomy was done. At this stage, the endolaser was done, was being planned. At this stage, I asked my colleague to take over the case, complete the endolaser, and inject silicone oil. And he's been been with me for quite a few years and has done a good job. At this point, somewhere down the line, he is due to visibility issues towards the end of endolaser, he wanted to do an AC wash and then clean, so that to improve the visualization. This when things get very complicated. The graft that is nicely sitting on the macular hole is displaced because the fluid jet from the anterior chamber has gone into the posterior chamber, and the fluid has displaced the autologous retinal graft. This stage, multiple attempts, he tried to pull the graft back again into the macular area. I was again called back into the OT for this particular case to again bring back the graft and place it in the proper location. I came back and again shifted it to the bimanual surgery under chandelier, and using bimanual procedure again the graft was taken and desperate attempt to keep it on the macula. I didn't want to shift to fluid again and do the entire surgery again, extending it further. So using bimanually with 2 forceps, it was managed to be kept on the macular hole. During the final successful attempt of trying to place this macular hole of the retinal tissue on the hole. At any point I was not in a position thinking of switching back to fluid and working, because that would prolong the surgery, and I was thinking at this stage when finally there was some bleeding from the edge of the macular hole. The cryo was done to complete the edges of the retinal retinectomy, but these are all pre-retinal hemorrhage. It was just the clot was fluid blood was required, and the clot was left as it is on the posterior pole. And this is how it looked on the first post-operative day, and subsequently in the long-term follow-up is recovered 3/60 vision, and from neovascular glaucoma to 360, we felt happy with the outcome. The other one is an interesting case of a guest from the retinal periphery during a macular surgery. So this was a case of a epiretinal membrane that we offered. She gave a history of multiple intravitreal injections for diabetic macular edema. We see that there is a epiretinal membrane, and she was offered a vitrectomy with membrane peeling surgery. 25 gauge vitrectomy was being performed, and then as usual, as a part of any vitrectomy surgery, some amount of surgery I try to do under air interface vitrectomy. So when I do the interface vitrectomy, I see that there's a peripheral kind of yellowish stick-like thing. Is I initially thought it could be an Ozurdex implant that was there, and my immediate instinct was to just remove it from there, because it was not required in the case of retinal membrane. It was looking like in a bat shaped. One end of it was thinner, the other one was wider. Towards the end, and I tried to my idea was to remove it in toto from the vitreous cavity, and I thought it was sometime during the course of the surgery I realized it is not, what I am dealing with is not exactly Ozurdex, probably some other implant, Illuvian implant came to my mind. I injected PFCL, and because multiple attempts of being made to eat this implant in the vitreous cavity, but it wouldn't, we couldn't cut this implant. So I tried holding the implant on one side and feeding it to the vitreous cutter, so that it could be eaten away more easily, and we could avoid enlarging the implant. But absolutely, this implant wouldn't get cut. So I tried, and finally I taken it out through the trocar itself as like a foreign body, and then the rest of the surgery was done as usual, the membrane peeling. This is what the actual surgery was that should have been completed quite some time back. This was not what was intended. So ultimately, I further said, I realized it is a Illuvian implant. What is a non-biodegradable kind of coating that is there, that is not possible to be cut with a vitrectomy cutter. I tried multiple settings of the vitrectomy cutters with the decreased cut rate and suction, but it was not. Finally, have time? I think this is time. Yeah, this is an interesting case of a vitreous hemorrhage following post-cataract surgery. The referral doctor had suspected that is a globe perforation, and this is a OCT scan done on day 1. We can see there is a macula is penetrated, and there is a hemorrhage in between the leaves of the edges of the macular hole, and this is at the end of 1 week. Yeah, but what's interesting is that we see that there are 2 macular holes in this patient. One is in the center, fovea center, and then one is in the superiorly away from the fovea. So she was taken up for surgery, and as also during the surgery we see there are 2. One is in the fovea center hole, and there is an extra foveal hole. For both we've done a inverted ILM flap technique, and 2 inverted ILM flaps were fashioned around both holes. The second one actually didn't need it was a small hole, it didn't require inverted flap, but it was scared to do any endolaser around that, because it would lead to scar expansion and involving the fovea at a later date. This is how it looked at the end of after 1 week, and this is how the macular hole closed, and both the holes, the fovea centered hole and the extra foveal hole, both closed successfully. Thank you.
Thank you, Dr. Reddy. Nice presentation. But in your first case, I want to highlight the one lesion, like everything, like in the anterior chamber, every manipulation has to be done prior to the final manipulation of the macular area. because even in the combined surgery of macular hole with the inverted flap, if you are then trying to wash out the anterior segment, the anterior chamber, that fluid may go inside and it will again displace the inverted flap.
That's one thing that should not be done.
In that case, you have used gas only. I think not oil. That's why this kind of situation has happened in your autologous retinal graft.
Yeah, yeah. That was because it's a recurrent RD. Oil was planned in that case.
Yes,
So
but
because the towards the end, the whatever AC wash was done, that fluid has seeped posteriorly and displaced the flap.
that happened just prior to the injection of silicone oil.
Yes, yes, yes.
Yes. But if you have injected the silicone oil, the jet of fluid from the anterior chamber through the zonils on go, that could have prevented. Yes. So, okay. Any questions from the audience? Yes, Dr. Jai, please.
Yeah, so I had a couple of questions for the first case that was there. So very beautifully managed case. So my first question was, after the graph got displaced, so how could you actually identify which side to be put first? That is my first question. Second is, for these patients, would you consider leaving the PFCL behind for about 2 weeks, because there is a macular hole, in which you have done an autograft, plus there's a retinectomy also has been done, just leaving behind PFCL for a couple of weeks and then directly doing just an air exchange. So that would help take care of the, a large retinectomy also. And when giving a prone position to these patients, it will help the graft to get the uptake would be slightly better. So what are the thoughts of the panel on those two things?
As far as the this which side is concerned, that's the last concern, because we are using it like a tamponade, like a what is a scaffolding tissue. Which side is probably not we are not expecting integration of the retinal layers in this case. Even amniotic membrane grafting these days, people say it doesn't matter which side you're trying to keep. So that's the last concern. But definitely, because it's a large 270-degree retinectomy, you can consider keeping a PFCL as a midterm, and then kind of.
Any other thoughts from the panelist?
Like you're doing the second stage surgery, it is also a good option, but I think just injecting silicone oil is good enough. Otherwise, if you are injecting, leaving this PFCL, so I think 60 to 70% of the PFCL should cover, then rest of the part is air. What do you think, Dr. Vishal? Okay, yes, yes. So, any other thoughts from the other speakers, like Dr. Shovik? Dr. Aditya?
I agree with you, Dr. Shubhendu. I think there is no need for additional PFCL tamponade for 2 weeks. Most of the times with silicone oil and with first surgery itself, the graft uptake is quite good.
Okay.
You may want to use a
direct PFCL silicone exchange because otherwise.
Yes, that's a good point.
You may also
so
want
you
to.
will not lose the flap.
You may want to use a Helon or something to just stabilize the flap in case you want.
Thank you.
So, okay, we are starting with our next speaker, Dr. Aditya Kelkar, for his longest day
Thank you,
session.
Shubhendu, again for inviting me for your course. So this is a patient, 65-year-old male, underwent vitrectomy for vitreous hemorrhage and TRD for left eye. Post-operatively, after 3 months, he presented with a PVR and a recurrence of retinal detachment, and subretinal silicone oil was seen. So here we are doing the fluid air exchange. You can see the fibrous proliferations, contractions on the retinal tissue. So a stain is used to identify all these membranes so as to allow easy removal. I do a retinectomy in the inferior side so as to allow the silicone oil to just come out from that area. It takes a little bit of patience, and you may want to create a larger retinectomy in order to allow that silicone oil bubble to come out, because a smaller opening in the retina doesn't make sense in these cases, because the silicone oil gets trapped and you may have to use a very high vacuum, and probably that might induce some more complications of intraocular pressure surge or hypotonia. While injecting PFCL, all of a sudden I see a surge. I don't know why. Probably there is a pre-existing break there, but the jet of the PFCL bubble doesn't seem to have caused a iatrogenic break in this case. Luckily there is a retinectomy inferiorly, so this PFCL gets floated up once I add another PFCL bubble on top of it. Once again I top it up so as to just allow the peripheral retina to fall flat. Endolaser is then performed and silicone oil is re-injected. One can do a PFCL silicone oil exchange also in these cases, but I routinely prefer this kind of a thing. So this is his post-op OCT and the retina looks flat. So the complications are obviously unintentional and inevitable in spite of all the precautions that you take, but prompt recognition and management can significantly change the course of these type of patients. Thank you.
Nice presentation, Dr. Aditya Kalkar. So without any much discussion, I am inviting Dr. Vishal Agarwal for his longest situations.
Thank you, Dr. Subindu sir, for having me in this wonderful instruction course. I'll be discussing two interesting cases which I think in the post-op period I am a little perplexed and might have done things differently, and maybe you'll be guiding me more on this. So, this is a patient who came with a thorn injury at around 12 noon in my OPD, and there was a nasal thorn, and you can see the vessel involvement which is nasal to the disc, and it was evolving end off, and the patient consented to surgery, and the vision was 6/6, and you can see the external entry wound of the thorn and the internal incarceration of the thorn tip into the retina. And then we took him at 4 p.m. around, and this was the surgery being undertaken, and we did a limited peritomy around the thorn area. And there was a pupillary membrane which was developing, and that was removed. It's a phakic eye. The patient is around 30 years old, and we injected visco and gently dissected the pupillary membrane to get a good view of the posterior chamber while doing vitrectomy. The cannula was visible. There was no hypotony. So after removing of all the membranes and clearing the anterior chamber, we went inside, and now you can see in just 4 hours the whole vessels of the arcade have been also involved, and this is the pre-op picture and this is the intra-op picture, and you can see the rapid development and the progression of the infection. And then we proceeded with the vitrectomy and induced the PVD and gently removed the tip from the underlying retina, and of course you can see that break over there. Did a thorough indentation and dissection of that area, re-injected tricot 2 or 3 times to see that whether any residual vitreous has been left, and special care was done to dissect the incarceration site and the entry wound, and laser to the posterior margin of the entry wound was done, and actually it was in the pars plana area, so it did not cross the retina through the entry wound. As you see, I'm dissecting out everything around the thorn and lasering the posterior edge of that tear, and of course the anterior edge of the tear was cryoed, and after that the thorn with the bimanual technique was removed, the scleral wound was sutured, and this is the cryo part, and I thought everything was fine. And this is the post-op day 1. You can see everything looks fine. This is the post-op day 7, and now you can see after 1 month there is a fixed fold and inferior fluid. The nasal periphery is fine. And then the second surgery was done after 1 month. The oil was removed. I had taken all the precautions because I know these cases can lead to reproliferation. I dissected the incarceration site, the entry wound properly, injected tricot, gave post-operative systemic steroids also, but still that site got reproliferated. And then I went inside, removed the oil, did the dissection, injected a small bubble of PFCL, did a retinectomy there, localized. This is the area where the thorn went inside the retina, and this time I took no chances and did a thorough chorioretinectomy, and so that there are no further recurrences, lasered it, did fluid exchange, put in oil again. And this is the post-op period, and the patient is doing fine. I have removed the oil. So, and the second case is the 45-year male presented, around a month after RTA with loss of vision in the left eye. The vision was PL plus. There was a large intraocular foreign body, radio opaque foreign body, and there was no history because he was unconscious after the RTA, so he could not tell me what went inside. And because it was such a large foreign body, we did a conjunctival peritomy just to explore the entry wound, but we could not find any entry wound. The cornea, as you can see, is clear, and the lens is clear, so it might have gone through the sclera, but there was no entry wound even after hooking all these muscles. We went ahead with the vitrectomy. There was a lot of vitreous hemorrhage, and on the B scan there was a localized inferior retinal detachment. And as you can see, this is all vitreous hemorrhage which we are clearing. And finally, we saw that large foreign body and dissected all the debris and the vitreous around it. And this I was operating at my second center, which is still a new center. We don't have all the equipments here. And you can see this is a glass piece which has gone inside the eye, and it's carbon coated. So it was giving appearance of a radio opaque iron foreign body. And I had only that ILM forceps and a magnet would not work, of course, and you can see the enormous size of the foreign body, so no amount of forceps stretching will catch hold of that. It's repeatedly slipping. It is causing additional damage because of the slippage, even though I have injected PFCL. As there was a localized RD in the superior quadrant, I tried to be a little aggressive. I made a posterior retinotomy, took this superior rectus holding forceps which has a serrated end, and removed it through that superior wound. And I knew it was a controlled step because there was already a RD there, and I made a retinotomy in a visible area and the sclerotomy in a visible area. I could not have done that through the ports because it's lying posteriorly and the superior rectus forceps is short in length. I sutured the wound after that, and you can see the area of the retinal tear because of that keratome entry. I lasered the posterior edge, cryoed the anterior edge, and lasered the rest of the breaks, iatrogenic breaks, which were caused because of the sharp edge of the foreign body. And this is the post-op period. The oil has been removed. The patient is doing fine after oil removal with good vision. This is the post-op OCT. Thank you.
Thank you, Dr. Vishal. That I have seen your first case in the morning session. The one thing to be highlighted, in end of situation, better to avoid the transferacetylene and use stipend blue to stain the vitreous. Second thing, in your second video, the glass foreign body, you have to protect the posterior pole. PFCL, I think better to use this Viscoat or Hilon GB to protect the macular area. That is the another tips. I think any other talk,
But
any
after
other
the
comment?
PFCL injection, actually it went towards the periphery of the retina, and it was not damaging the macula at least. So that worked. But there were small breaks because of the sharp edge in the periphery, not at the macula.
Macula. Dr. Reddy?
What else could you have done to retrieve that foreign body if you have limited resources in that OT setup in that day, and you're not anticipating a glass foreign body of that size? What will you do?
Dr. Manish Bapai has invented one forceps.
I know that. We don't have that in our OA setup. With that limited resource, what would you have done differently?
Yes, Dr. Devendra.
There is a way to modify your light pipe to a chandelier after cutting and putting it in that. So sometimes these unusual large foreign bodies, it is very handy to be bimanual. So if you don't have a regular machine and regular chandelier, if you have a spare light pipe, you can cut it and push it through one of the cannula, tape it. It will work like chandelier, and then bimanual handling is easier.
But sir, in bimanual, the forceps will not catch hold.
I'll tell you, when your keratome entry was too posterior, I think it should be at 3 millimeter.
But the superior rectus forceps will not go through a 3 mm. It's at the macula, the foreign body.
You make a cruciate kind of wound rather than a linear wound.
Okay.
Make a cruciate wound. There are videos on that. We have done it to remove IULs, PMMA IULs.
Okay.
They are also 6 millimeter wide.
Thank you.
Excuse me.
Yes.
Yeah.
Yes.
Another suggestion which I had tried, whether if a suture or a Gore-Tex suture, whatever you have,
Lasso technique.
yeah, lasso
Okay.
technique, you just hold it and make the snare around the
Yeah.
body and at least elevate it
Yeah.
and then remove it.
Okay. Thank you.
So I'll invite our next speaker, Dr. Shobik Da.
अच्छा भाई, great video.
Hello everyone. Hope you all are enjoying this session. Thank you Dr. Shubandhu Baral sir for giving me this opportunity. Today I am going to present you two of my very interesting cases, and it is a audio visual presentation. So let's see.
Breaking the ice.
Volume.
Vitreoretinal solution in a corneal decompensated eye. Iridocorneal endothelial syndrome represents one of the most challenging interfaces between anterior and posterior segment disease. We present a 42-year-old male with IC syndrome presenting with microcornea, a pinpoint eccentric pupil, iridomuscular stromal changes, and vision limited to hand movement close to face. Severe corneal decompensation precluded any posterior segment view. Intraoperatively, the iris hooks were placed to overcome the distorted pupil and restore visualization. Following lensectomy, a true pathology was revealed, a full-thickness macular hole related to retinal detachment with multiple peripheral breaks. A PFCL-assisted inverted ILM flap technique was performed to address the macular hole. Then a complete posterior vitreous detachment was meticulously completed with the forceps and cutter. And a secondary retinotomy allowed for complete subretinal fluid drainage. After achieving stable retinal reattachment, silicone oil tamponade was instilled, and the anterior chamber was stabilized with viscoelastics. After 3 weeks, the retina remained attached with a successful type 1 macular hole closure. Despite residual corneal edema, best corrected visual acuity improved to 6/60. The patient is now planned for silicone oil removal, DMEC or DESEC, and a secondary intraocular lens implantation. With no prior PubMed index report of macular hole associated retinal detachment in IC syndrome, this case demonstrates that even in the most hostile IC eyes, strategic vitreoretinal intervention can successfully break through the opacity and restore anatomy where the vision once seemed lost. Thank you for your kind attention.
Now going to my second case.
Combined cataract and vitrectomy surgery demands absolute control of intraocular pressure dynamics. In this video, we present a rare but preventable intraoperative complication, the pressure trap. This was a case of proliferative diabetic retinopathy with a significant amount of cataract. So after uncomplicated phacoemulsification, a multipiece IOL was given in the bag. Anterior chamber was filled with viscoelastics and I started vitrectomy. So you can see it was a routine case of vitreous hemorrhage. Vitrectomy was completed and the laser was applied. As there was an iatrogenic break in the extreme periphery of the superior retina, I have to barrage it. Then fluid gas exchange was done and I was about to finish this case. But just before removing the speculum, I suddenly realized that, oh God, I just forgot to wash the viscoelastics from the anterior chamber. So without any hesitation, I started irrigation aspiration and suddenly everything was messed up. The IOL was dislocated. I tried to relocate the IOL using a dumbbell with irrigation on. But then, just boom, posterior capsule was ruptured. Air bubble popped up into the anterior chamber, and the IOL took a deep dive into the posterior cavity. I was stunned. I was thinking why this was happening. It was happening because in a vitrectomized eye with a gas tamponade, anterior chamber irrigation performed out of sequence created a sudden posterior chamber surge. The resulting pressure imbalance led to abrupt intraoperative intraocular lens dislocation. This case highlights a critical surgical lesion. In gas-filled eyes, sequencing is not optional, it is decisive. Thank you for your kind attention.
Thank you.
Thank you, Dr. Shovik, for nice cases. Dr.
One
Vishal.
one small
Yes,
comment that I'd like to make is IC syndromes and where you have anterior dysgenesis. I've had performed RD surgery and subsequently the IOP shoots up. So these are patients who need careful monitoring of the IOP, and I've had very bad situations where tube shunts have had to be put in CPC, and because many of these patients might not be able to afford shunts subsequently. So I have had very bad experience. So this is
So
just one
actually,
point.
that case occurs in case of accidental Rieger syndrome.
Yeah,
And
yeah.
this is a IC syndrome. Here the cornea is mainly involved.
Because these are kind of borderline situations where you have anterior segment dysgenesis. You can also have trabecular meshwork dysgenesis. So and you can have this IOP rise. Yeah.
But you had a good view of the fundus, and during vitrectomy, the temporal area of the cornea was comparatively clear than the nasal area.
Yeah.
So there was no difficulty in maneuvers
No, no.
intraoperatively.
So very good afternoon. So coming to our last talk, that is my longest days in my routine practice, like operating on an elevated macula. It was a case of mature cataract with PLPR vision, and you can see there is elevated macula is quite elevated, so, and there is like quite dense cataract. So I started doing phacoemulsification first to get for the proper visualization of the posterior segment. So I finished my phaco nicely, and finally I put the IOL without any issue. So then I gone inside. When I went inside, there was like multiple membranes, and that are like kind of vitreous chysis membranes, lot of traction on the macula. I have decided I have trimmed all the vitreous membranes all around the periphery, and this dissecting all the membranes. Now I have to go tackle this macula that stained the macular membrane with the type and blue dye, then try to remove the ARM part. That was quite extensive ARM was there, and that I was operating on an elevated boggy detached macula. And while removing this ARM, I was seeing it is quite densely adhered to the retina, and know the retina is quite it is becoming elevated, and for that reason I again stained with type and blue dye as well as this ILM dye BBG, then injected PFCL to have just to counteract the distractional forces that arise from my peeling membrane and the ILM membrane. So whenever you will get the detached macula, and all the macula is quite boggy, so in those situations to work like nicely in a controlled manner, you have to use this PFCL. Otherwise this PFCL otherwise this boggy working on this boggy retina or the detached retina, you may create iatrogenic retinal break. You can see the macula retina is quite elevated, and even under the PFCL. And finally I have aspirate out all the PFCL bubble, but suddenly I realized there is some two kind of atrophic breaks there in just above the superior vascular arcade. So I just aspirate out the fluid. Maybe it was a case of combined retinal detachment because of this long-standing traction, and patient came with the macular with mature cataract. So postoperatively with the gas tamponade only, the macula remains all attached and with a nice visual recovery. Now coming to the my second talk, submacular BBG. So it is a case of central retinal detachment with macular hole with posterior staphylinoma in high myop case. So cataract was already done. So I started doing vitrectomy and then stain the posterior highlight phase with the triamcinolone acetonide and remove all the membranes, premacular membranes. And it was a high myop case. You have to remove all the vitreous chisis membrane because that was quite evident on the OCT. And uh, after doing all kind of vitreous manipulations, I am just trying to aspirate out the central subretinal fluid through the macular hole, just to avoid migration of the BBG dye going in the subretinal spaces, because submacular BBG dye can be toxic for the ellipsoid zone as well as the RP atrophy can occur. So, but still, even after aspiration of all the fluid and injecting PF cell, just see there's still the submacular BBG went inside. The BBG went inside the detached retina, and you can see in the submacular nicely BBG stained submacular fluid. And so I have done the inverted flap under the PF cell all around the hole. Then I have to aspirate out all this subretinal BBG. Then I opened up all the this inverted flap again just to open this macular hole part. Then it started doing fluid exchange, start aspirating from the periphery, because PF cell contour is from, it is a convex contour from, and I have aspirated all the PF cell bubble and try to aspirate out the all subretinal BBG submacular. And just see the part of the ILM has been just I have aspirated out and accidentally, and but not all. Then I have slowly aspirated out all the submacular BBG dye. It is not absolutely non-toxic for the subretinal space. There are a lot of literature has already published for the toxicity of BBG for the ellipsoid zone, as well as it can cause RP atrophy. A little bit of ILM left at the margin of that in the temporal parts. I just placed it, but still there was some kind of fluid. Again, it was appearing. So after repeated aspiration of this fluid, I just the central macula become flat, and I have placed this residual flap in a small eye, without any hesitation, and finally the patient gained 6/9 vision after 3 months under gas tamponade. Now, my third tricky situation is innumerable foreign bodies. Like innumerable foreign bodies, in this patient has a history of playing, like as a child who was playing in the jungle kind of area, where just he has some kind of injury. He was not very much sure that what kind of injury happened to him, and I have seen like a lot of multiple whitish lesions, and you can see the foreign bodies. Actually, they are all CP hairs, caterpillar hairs, one by one. First I have removed, this is the second one, caterpillar hair. You can see multiple peripheral caterpillar hairs. So I went inside, checked all the vitreous base. Again, I have detected a few more kind of lesions, whitish lesions. Then I did repeat vitrectomy all around these areas, and seen they just see these caterpillar hairs are just poking from the retinal surface, and you have to slowly more this is the fifth one. I have removed this caterpillar hairs. Patient will not give this kind of confirmatory history. You have to find out what kind of foreign body is there. Previously we did all X-ray, all this thing. The foreign body was not detectable because not so kind of you can't detect it, because the bone density index for these foreign bodies are very low, so you cannot detect separate it from the underlying overlying bone. Thank you for your presence hearing. So I am inviting all the questions, if left, for the speakers as well as for me. Any comment from the my co-instructor?
Second, regarding the second case, actually, macular holes, in retinal detachments, if you drain the macular hole with a soft tip cannula, and you are almost certain that it will close. So I use this technique. I do not induce a RD. I just do a massage. I do not do inverted flap for large holes. Just do a macular massage with the soft tip cannula and drain out the macular fluid, even in attached retina. And so your case was already detached. The retina is pliable, so
So
that did the trick.
you mean to say that without doing the ILM peeling, also the macro hole
No,
will be
you
closed?
have to do the
I
island
have to
peeling.
ILM peeling.
Yeah,
That's
yeah,
why
yeah.
I was intending to inject BBG dye just to prevent the subretinal migration of BBG dye. I have aspirated out the central subretinal fluid through the macro hole. Then I injected the BBG dye. Then I injected the PFCL. I tried to aspirate because under air it is difficult to do the ILM peeling. So I have
Absolutely.
injected the PFCL. But still the dye has went inside.
Yes, yes.
Any comment from the Dr. Vishal?
I want to make a comment on the third case, very beautifully managed and a wonderful video. I was just observing when you were removing those caterpillar hairs, there was some, it was not, it was stuck to the vitreous, and especially at the last hair when you removed it, there was a bleed. And then when and actually what was happening, that you induced the PVD after that last hair was removed, because I saw that heme coming up in a V ring. And my only point is that if you would have induced PVD before and then removed all the hairs, the break size would not have enlarged, and it would be a little less messy. Like, yeah, same. The heme is on the posterior pole, and now you are inducing the PVD. So my sequence would have
No,
been that I would have induced the PVD first
that
and made the hair impaction sites free of vitreous, and then do the rest of the maneuvers. If I'm not
basically,
wrong.
I have not used this triamcinolone dye to detect this residual vitreous. PBD was separate means from the disc, but it was the residual part of the vitreous
Yes, the residual part.
schisis part
Yes.
that remained attached. So that
Dr. Subhendu, how
yes.
regarding subretinal toxicity of the BBG dye, how strong is the evidence? Because sometimes my experience we've seen, but it's not so toxic.
If you compare ICG, trypan blue and BBG, BBG is the safest dye, but still the reports are there, any dye which is colorful, not colorless, go inside the beneath the retina, it is toxic. Toxic because the evidence, the report has already there that it can cause ellipsoid zone disruption, RPE atrophy and foveal atrophy.
Subhendu, regarding the subretinal BBG in macular hole, before injecting PFCL, you could have done fluid exchange. So you could have cleared the dye from the subretinal space.
No. I have aspirated out the fluid from the subretinal space. Central RD has gone. So now it is attached retina. Then I injected the BBG dye.
Yeah.
Knowing the fact the BBG won't go subretinally. Then I have injected PFCL. Then I have detected still the BBG dye gone inside because of the lot of traction. Maybe it is that
come back to fluid again.
because of the posterior
removing the
staphyloма case was with the posterior staphyloma. That's why the dye went inside.
So a similar case happened.
And the taut ILM. Yes.
Still you can remove it under fluid. You know.
No, at that situation the PFCL was there.
You have to remove the PFCL, go back to fluid, and then do fluid exchange. It will come.
That same phenomena could have been repeated.
No, because the small amount of dye was there inside. Okay. So
It's not small, it's quite large, almost
But still, if you do fluid exchange, it will
3-4 disc diameter dye was there.
So a similar case was, that happened, the similar situation happened with me. So what I did was, sir, I did not remove the whole PFCL. I made it half a bubble and tilted the globe towards the temporal side. So now if you aspirate the dye, the only way the dye can go is the nasal quadrant, because temporally there is a small PFCL left. So instead of removing the whole chunk of the bubble, just keep half the size, and then it is very easy to remove.
Then you can do the LMP.
Yeah.
That's right. Okay, thank you. So now we are closing our session. We are handing over the session to the next speakers. Thank you.